Welcome, everyone. I am Alison Bartolucci from the Center for Advanced Reproductive Services at the University of Connecticut in Farmington, Connecticut. It is a pleasure and honor to be here co-hosting the 29th session of the International IVF Initiative. This session will focus on, quite literally, the coolest topic in our field, cryopreservation. The advancements in human embryo and gamete cryopreservation that have occurred over the past few decades have revolutionized the way in which we treat infertility. The ability to successfully cryopreserve gametes and embryos has provided us with the opportunity to not only preserve fertility in both the short and long term, but to also offer more comprehensive and in many ways safer IVF treatments to a broader population of patients. For these reasons, optimizing our cryopreservation techniques and protocols is of the utmost importance in order to enhance laboratory, pregnancy, and fetal outcomes. For our session today, we have lined up some of the world's leading experts to share their research and discuss the most important factors involved in achieving and maintaining a successful cryopreservation program. Before we get started, I have just a few housekeeping details and reminders. Please note that all questions to the speakers must be asked through the Q&A feature. Please do not use the chat function for questions, as the panelists do not respond to the questions posted in that section. Submitted questions will be answered either verbally by the speakers or in writing by the panelists today or after the session. Answers will also be posted on the I3 website. We ask that you please do not use the Q&A or chat area for solicitation of any products or companies. Lastly, for videos of previous sessions, a recording of this session, and information about upcoming sessions, please go to ivfmeeting.com. You can also find the disclosures and bios of the speakers here as well. Okay, so without further ado, I will turn it over to my co-host and vitrification virtuoso, Dr. Peter Nagy.
Thank you, Alison. It's great to be here, and thank you for everyone for joining to this webinar. I am Peter Nagy. I am embryologist working at Reproductive Biology Associates in Georgia, United States. As many of you know, the topic of cryopreservation is indeed near and dear to my heart. And if you just permit me to go back a little bit in history, in 2005, when everyone, including also us here at RBA, was using the not very efficient slow freezing, we embarked on a new journey, and we started to experiment on vitrification. My colleague, Dr. Jeremy Chang, who is actually the first speaker at today's webinar, he was the lead scientist in this experimentation, and within a year after extensive animal studies, was able to establish a protocol and try it also on human oocytes, that vitrification that worked. Of course, with today's experience, this may not seem as a big deal, but back at that time, it has been a challenge for many reasons, because there were actually not any published protocols about it, or there were no tools and no vitrification solutions, so everything had to be homemade. So let me now go ahead and introduce my colleague, Jeremy Chang, who obtained his Bachelor of Science in '94 and Master of Science in '96 at the National Chang University in Taiwan. Then from '98, he was an embryologist at Lee Women's Hospital in Taiwan. And in 2001, he joined the Center of Regenerative Biology at University of Connecticut and obtained his PhD in 2005 on haploidization. He's currently director of the cryo unit at Reproductive Biology Associates here in Atlanta. As I mentioned, Dr. Chang has successfully developed this highly efficient way of vitrifying oocytes and embryos in 2005 that became the basis of the first vitrification-based US donor egg bank that is called My Egg Bank. So it is really a great pleasure and honor to have Jeremy with us, and we are looking forward to your presentation on principles of cryopreservation and optimization of vitrification. Please go ahead.
Thank you, Peter, for a very kind introduction. I'm so honored, and it's a great pleasure to be invited by I3. Okay, so I'd like to talk about the principles of the cryopreservation and how to optimize the vitrify. Okay, So I would like to briefly introduce the pioneering studies that laid the foundation for the cryopreservation principles. So about 7 decades ago, it's the first time that CPA was used to dehydrate the reproductive cell for cryopreservation by Dr. Chris Podge. And since then, the use of a CPA initiated the following breakthroughs. So in 1979, mouse embryo, and 83, human embryo, and 86, human oocyte was slow frozen. And in 1985, the very first proof of principles paper for vitrification was published by Dr. Roh and Fahy. It opened a new page for cryopreservation for reproductive cells. So in 1990, human embryo, and in 1999, human oocyte could be vitrified. So ice is the enemy for cryopreservation because ice can damage membrane, including cell and organelles. In order to avoid ice, we need to remove water from cells. To dehydrate the cell, there are 2 categories of CPA can be used. The first one is permeable, such as glycerol, DMSO, propanediol, and ethylene glycol. And we use a permeable to replace water inside the cell. And the second category is called non-permeable. So usually they are a large molecule and they cannot penetrate through the cell membrane, such as sucrose, trehalose, and PVP. So we use them to create the concentration gradient to pour the water out of the cell. Okay, so with the background of the CPA, cryoprotectants agents, then let's start with the techniques. Start from the slow freezing. So usually we dehydrate the embryo at the room temperature using the CPA. And then we gradually drop down the temperature to the point very close to the freezing. And then we do the manual ice seeding to grow the ice in a controlled way. So as the temperature going down slowly, the ice will also grow slowly. So the solute's concentration goes up. Therefore, it creates the concentration gradient to pull the water out of the cell. When the temperature reaches to -35, so the dehydration is almost complete, and then we just directly plunge into the liquid nitrogen. And then for the vitrification, so we treat the embryo with the high concentrated CPA at room temperature, and then go directly to the liquid nitrogen. So regarding the principle of the vitrification, the first requirement for that is extremely rapid rate of cooling. Even pure water can be vitrified if the cooling rate is high enough. However, practically, it is very hard to achieve the cooling rate that high. Therefore, the use of a highly concentrated CP is to facilitate the vitrification process. So here, to achieve the glass state, we need to have extremely rapid rate of cooling, and then to cool the temperature to a certain degree. And that certain degree is called glass transition temperature point. So for the water, the glass transition temperature is -146. So if we add a CPA, the glass transition temperature can be raised to -130. So if we look at the cooling part, we usually do the vitrification from room temperature to -196. So the danger zone, the ice forming range, is from the melting point to the glass transition point, which is from -15 to -130. So we want to pass through this range as quick as possible in order to avoid ice forming. So on the same page, get warming. So we usually starting from -196 to 37. So the ice forming range is starting from the vitrified point And this point is a little bit above the glass transition point, which is around minus 110 to the melting point is minus 15. So we also want to make sure the spacemen to pass through the range quick and to avoid ice. Okay, so here I use a very popular vitrification protocol as an example to see how much CPA we add in the vit and warming solution. So for example, here for the vitrification, we add 15% ethylene glycol, 15% DMSO, and the 0.5 molar sucrose. As you can see here, the osmolarity can go up to more than 5,000 mini OSM. So if we see that, if we see the ES solution of the VS, so you can see the osmolarity change could be huge, especially between procedures. And if you look at the rehydration procedures, the osmolarity change can be very, very dramatic. So here raise two concerns. One is osmotic shocks between procedures. Secondly is the toxicity of the CPA. So based on the two principles, we can summarize how to improve vitrification in two ways. The first is how to increase the rate of cooling and warming. And the second is how to minimize the negative impact of cryo solutions. So how to increase the cooling or warming rate? It's all about heat conduction. For example, when we do the embryo loading for vitrification, we will try to minimize the loading volume in order to increase the heat conduction. After plunge into liquid nitrogen, the embryo will be solidified and stuck onto the device. So at the moment, we should consider the embryo and the device become one entity. Therefore, the thickness and the material of the device matters a lot for the heat conduction. Also, for the warming, the shorter time for the embryo to detach from the device, the better. Also due to the heat conduction. So according to Newton's law of cooling, the rate of a heat loss of a body is directly proportional to the difference in the temperature between the body and its surroundings. So simply it says, when the temperature difference is bigger, the cooling rate will be higher. We can use slush nitrogen to increase the cooling rate because the slush nitrogen has an even lower temperature than the liquid nitrogen. And regarding the warming part, in the same way, so we can, the warming rate can be increased if we warm the oocyte or the embryo directly into the warming solution, which is higher than 37 degrees. The question here is, how high is too high? Because we don't want to overcook the embryo. But there is an interesting paper published a few years ago by Dr. Mazur's lab. The infrared laser can be used to warm up the vitrified oocyte. So in a millisecond, the temperature can be increased from minus 196 to minus 3. So it directly passed the ice forming range. They were able to achieve 90% of a survival rate. And then CPA composition. CPA composition can affect the glass transition point and the devitrified point. As the figure shown here, you can see, so if we increase the concentration of the CPA, you will see the devitrified point can be raised from minus 105 to minus 85. So when we use the different composition of the CPA, the minimum required cooling or warming rate will also be different. So the second way to the improvement is to reduce negative impact of cryo solution, such as CPA toxicity. For example, the DMSO and the propanediol toxicity have been reported before. And then in the very beginning, we were trying out 3 different kinds of a CPA, use mouse oocyte vitrification as a model. And then we checked the survival rate and the blastocyst rate, and also the blastocyst count, cell counting. And then the conclusion is that ethylene glycol outperformed the other 2 CPA as a best CPA candidate for the vitrification. The other idea to reduce the CPA toxicity is to use the combination CPA instead of a single CPA. So in this case, we can lower the concentration of each individual CPA, therefore reduce the toxicity of each individual CPA. And then according to the mouse oocyte study, and we compare the single versus the combo, we did not find the difference. And then we did the further study. We were using the human sibling oocyte to compare single versus combo. And then again, at least for the in vitro part, we did not see the difference between the single and the combo regarding oocyte survival rate, fertilization rate, and blastocyst rate. Since we know the osmolarity change can be huge when CPA is used for dehydration and rehydration, to minimize the osmotic shock is another way to reduce impact. For example, the standard warming procedure is 3 steps. So we usually transfer the embryo to the 1 molar sucrose to 0.5 to 0. And it can be modified into 5 steps, like from 1 molar to 0.75 to 5 to 0.25, and then to 0, in order to mitigate the osmotic impact. Even we could use the microfluidic system to create the microenvironment for less impact for osmolarity change. And then pH. HEAPs and MOPs are often used as a buffer system in IVF media to maintain pH, since we know pH can be varied when temperature change. For example, the proper pH for embryo using HEAPs buffer solution is at 37 degrees, and the proper MOPs, the proper pH for embryo using MOPs is at 25 degrees. So the question here is, which buffer system fits the best for the vit or warming procedures? And the other question is, can we use the combination of the half HEAPs, the other half MOPs in the vit and warming solution? Or we use them according to their handling temperature? And those questions also need to be addressed in the future. I hope I can share some data with you soon, because those data studies still undergoing. And this one is using biological approach to improve the vit outcome. The concept here is, if we cannot change the environment, then we change the embryo to adjust to the environment. So the cytoskeleton stabilizers, they have been used to precondition the embryo before doing vitrification. For example, the cytoclasmin B, CCB, is one of the cytoskeleton stabilizer, which can relax cell membranes. It has been used to improve the outcome of the porcine blastocyst vitrification. In addition, we also found the CPA, like ethylene glycol and DMSO. They can actually stabilize the microtubules and induce the MTOC, which stands for microtubule organizing center, in the oocytes. Even when we put the oocyte into the 4 degrees C for 30 minutes, the bipolar spindle still can be well maintained, even if the media has the CPA. Therefore, the cytoskeleton structure may play a role in resisting the impact from vitrification. Okay, future direction. I know a lot of people have concern about the human handling variation, especially for vitrification. So in the future, automation can help us improve consistency, especially for certain critical steps, like loading the embryo on the device. And also with the help of the AI, we may be able to predict outcome, especially for the oocyte vitrification, and also optimize the vitrification protocol using the morphokinetics data. And second point is the epigenetic concern. And this is the Denmark study published in last year. And they found the baby born from the FET cycles were associated with the increased risk of childhood cancer due to the possible epigenetic alteration. So based on the time frame, the study was collected data from 1996 to 2012. So I would assume most of the cases in the study were using slow freezing method. So therefore, it will be very, very important to find out the outcome for the vitrification. So I hope we can see the data in the near future. And it's very extremely important for all of us in ART field. And by this opportunity, I would like to thank my mentors, Dr. Peter Nagy, and also Dr. Cindy Tian. They have been supporting me since I was a graduate student. And then I also would like to thank my colleagues who I work with. They inspire me all the great ideas for the research. Thank you very much.
Thank you very much, Jeremy. That was an amazing presentation, very informative. Looks like we do have some questions. One that is of a couple technical questions. How important is the ambient temperature of the lab when doing vitrification and warming, for that matter?
Right. Regarding the ambient temperature, I think let's talk about the freezing part, the equilibration part. If the ambient temperature is higher, then the equilibration time should be shorter because of the osmolarity issue. Because the water will be easier to penetrate through the cell membrane if the temperature higher. It's a very good question.
Yeah, thank you. So our next speaker needs very little introduction, as the topic of oocyte cryopreservation is rarely discussed without acknowledging her work. Dr. Anja Cobo is the director of the cryobiology unit in the IVF lab at EB Valencia, where she also directs the vitrification training program. Her contributions to oocyte cryopreservation began as part of her master's and doctoral thesis and have continued on in her publications of over 100 articles and book chapters on cryopreservation in IVF. Unfortunately, Dr. Cobo was unable to be with us live today, but luckily she pre-recorded her presentation with Dr. Nagy, so we have it here for you to enjoy now.
Thank you, Peter, for the very nice introduction. I feel really excited to participate in this webinar, and I think this initiative, what you're doing, it's really very useful and very interesting for all of us working in our field. So I really feel honored to be here today. So the title of this presentation is The State of the Art in Cryopreservation, and we are going to review the outcome of oocytes and embryo vitrification. So vitrification actually has changed our way of working in our daily clinical practice, because it has improved the outcomes we were achieving with the slow freezing back in the days with the embryo cryopreservation, and it has allowed the female gamete to be successful cryopreserved. So the banking has made possible the ovum donation programs with vitrified oocytes, with bring great flexibility to these programs. It has also allowed the fertility preservation, which was not available prior to vitrification. It is also useful to manage any other different clinical situations like poor responders and others. And in other situations, I would say more circumstantial. With regards to embryo vitrification, it has represent a great improvement in our in the results we achieve with cryotransfer because of the increased success rates we achieve with vitrification as compared with the slow freezing method. I would say that vitrification, it is also a fundamental tool in our actual PGTA programs, and it also has allowed a completely new strategy in assisted reproduction, which is the freeze-all strategy. According to these two societies, the Alpha Consensus Meeting and the Joint Consensus between HRA and Alpha, benchmark values for survival rates range from 80 to 99%. And I would say that this could be possibly due to the difference in cryotolerance from the oocyte to the blastocyst. But I would say that this could be also due to technical issues. Embryo vitrification, as I mentioned before, it is really it is used most these days. So this is data from the Spanish register, and we can see here that in 2009, most of the cryotransfers, the embryo transfer were performed with fresh embryos. But in 2016, half of the embryo transfers were actually cryotransfer. So this shows how embryo vitrification is really a fundamental part in our practice today. The most frequent embryo developmental stage that we are actually cryopreserving is the blastocyst. So I'm gonna stop a little bit in the evaluation of the results we are achieving with the vitrified blastocyst, and especially with the biopsy blastocyst. Because let's say that these blastocysts, these embryos, are quite in a specific different situation. Let's say they could be more vulnerable because they have a hole in the zona pellucida, and it is documented that this could modify the process of dehydration and the permeation of the cryoprotectants. So I think it's valid to ask ourselves the question if this can compromise the embryo viability after vitrification. So this is data from our unit, from our group, and it shows the effect of the morphology, the day of the biopsy, and the expansion degree prior to vitrification. So we could vitrify after the biopsy, the embryos still collapsed. They could be initially hatching, or they could be totally hatched. And as you can see here in these two figures, the worst scenario if the embryos are poor quality embryos and if they are totally hatched. And this is true for survival rate and for implantation rate. And we can achieve a great or the highest success rate if the embryos are top quality and if they are day 5 embryos, and best results if they are still collapsed or if they are initially hatched. And again, this is true for survival and for implantation rate. And this is consistent with which was published by Simadomo in 2018. And as shown by these authors, they concluded that the biopsy did not impair the survival rate after blastocyst vitrification, that the lower survival rate was related to the morphological quality and the slower blastulation. And they recommend that vitrification should be done during the 30 minutes after the biopsy when the blastocysts are still collapsed. So this is totally consistent with which we are observing in our labs. So they evaluated the risk of regeneration after warming or not re-expanding after warming, considering these two factors. Successful embryo or blastocyst vitrification has also bring a new strategy, which is the freeze-all strategy, based on the rationale that this way, if we freeze all the embryos, we will do the embryo transfer in a more physiological environment. According to this, there's been quite a debate about the usefulness of this strategy to increase the results after IVF. And according to this, a couple of studies published in the in the New England Journal of Medicine 2018, live birth rates were comparable between freeze-all strategy and fresh embryo transfers in normoambulatory women or in women without PCO. But this was of course useful to prevent the OHSS. So according to these authors, it is not useful to increase IVF outcomes, but it is useful in different, for example, to prevent the development of the OHSS. This is a meta-analysis which was published a year after, and it shows by Broke and co-workers, and it shows that actually there is no difference in cumulative live birth rate in the overall population or in normal responders, but high results were achieved after the freeze-all strategy in hyper responders and in PGTA cycles. Of course, it is useful to lower the OHSS risk, as we mentioned before, and there is also an increased risk of preeclampsia after these cryotransfers. This is a more recent review from February 2020, and according to these authors, with the current knowledge about freeze-all and blastocyst or embryo vitrification, we should focus in optimize the protocols and their applications to specific populations. But I think really this is embryo vitrification is working really, really successfully. So to analyze, let's focus on the oocyte. And the first thing I would like to analyze is the oocyte survival. So I think we need to consider among the all factors related, these three main factors, which is the population, age and indication, technical issues, and the oocyte quality. This is a study we published in 2015 in our ovum donation program. And in that time, we published that there is a proportion, fortunately it's a small proportion, low proportion, but still there is, where survival rate is 0%. And this is quite notary because these are healthy young women. So this is a very selected population. And as you can see here, there is other ranges of suboptimal survival rates, which are really not acceptable with the current protocols we are using. And as I said, this is really noticeable because these are young, healthy women. But I think which is really more interesting is that there seems to be a pattern of recurrence in this survival failure. Let me explain. If we have, for one donor, if we have survival failure in the first cycle, the probability to have survival failure in the second cycle will multiply by 2. And if there's survival failure in the 2 first cycles, then the probability to have another survival failure, it multiplies by 5. So there seems to be a recurrence pattern in this survival failure, and this is specific from some from specific individuals. In the study I just mentioned from 2015, we tried to develop predictive model for survival failure. So we consider the number of oocytes in the cohort, which was not related. Also, the parameters are body mass index and the stimulation parameters, which were not also related. And I think this very important issue, which is the storage time, At that time, we analyzed the oocytes, donors' oocytes, which were stored for up to 5 years with no impact on survival, implantation, or clinical or ongoing pregnancy rates. And this is consistent with which we are observing in a fertility preservation population. So we have survival rates for elective freezers and for cancer patients. And we have done this analysis for 8 years or more with no impact on survival failure. So I think this is interesting analysis. This is another study published by Ayla Coello from our group here in Valencia, showing how the oocyte morphology, different dysmorphisms, are also not related with survival rate, with the blastocyst formation, or with the usable blastocyst rate. For usable, I mean those blastocysts that we cryopreserve or that we would transfer. So far, we haven't detected any variables able to forecast survival after vitrification. But let's analyze the effect of the age and of the combined effect of age and indication on survival and on clinical outcome. This was a publication from 2016 in Fertility and Sterility in a fertility preservation, elective freezers again. And as you can see here, survival has a direct impact on survival, age has a direct impact on survival and on clinical outcome, live birth rate and ongoing pregnancy rates. And these differences are even more clear if we compare between the youngest and the oldest group. So there is an impact of age on survival and on clinical outcome. Of course, these are not donors, these are elective freezers. This is another publication from 2018 in Fertility and Sterility. This is a special issue to celebrate, the 40 years of IVF. So we have here, I like this slide very much because we have here a whole picture of different populations using vitrified oocytes so far. So we have donors, we have full responders, elective freezers, and cancer patients. Of course, for autologous oocytes, we have split the population according to age. If we focus in older patients, older than 35 years old, the results of survival and clinical outcome are pretty comparable because this is because of the age, and as we just mentioned, age has a direct impact on the outcome. But if we focus on the younger populations, including donors, the results are really comparable between donors and elective freezers. These results are pretty much the same with regards to survival and clinical outcome. Results worsen if there are poor responder, and the lowest results are achieved by cancer patients. So there is a differential outcome in terms of survival and clinical pregnancy rates and live birth rates according to different populations. We actually showed this in our study, comparing elective freezers versus cancer patients after fertility preservation, but we were not able to show, statistically speaking, to show the direct relationship between the cancer disease itself and survival and the cumulative live birth rate. But again, what we demonstrate clearly was the effect of the age on the final outcome. And this is another slide, another different population, just showing quite the same analysis. These are endometriosis patients. Let's focus on the younger group. These patients aged 35 years old or younger. And as we can see, survival rate, all these parameters, implantation, pregnancy rates, and cumulative live birth rate were lower in endometriosis patients, age matching groups, all of these young women. So this could be pointing to a direct effect of the oocyte quality, a compromise in the oocyte quality, which, by the way, in the endometriosis group is well documented. Finally, this is the last series of slides of this talk. I would like to evaluate the embryo development after using the vitrified oocytes. This is a study from 2017. This is a morphokinetic analysis of embryos originated from vitrified oocytes in our open donation program. And we have compared with embryos originated from fresh oocytes. As you can see here, or here, I think it's more clear. We can see that there is a delay of about 1 hour in all of these morphokinetic variables when embryos were developed from vitrified oocytes, and these differences were statistically significant. So in other words, it seems that embryos from vitrified oocytes seems to be slower. But this parameter here, the CC2, which is the replication of the, when the replication of the DNA is taking place, is comparable between the two cycles. In that could be maybe the explanation why implantation rate and clinical outcome are comparable between fresh and vitrified oocytes. So the other analysis, the other explanation could be that embryos originated from vitrified oocytes, it takes longer for them to restart all the machinery to start all the embryo developmental events. These results were published by Foreman in 2012, and he shows how embryos coming from vitrified oocytes show lower developmental potential. And this is data from our open donation program again, and as you can see here, we have 70% blastocyst weight formation, and it is 65 for embryos from vitrified oocytes, and these differences were statistically significant, although clinical pregnancy rates were at the end totally comparable between fresh and vitrified groups. And this regression analysis here shows that actually blastocyst formation is related to the source of oocytes, if they are vitrified or fresh, but it's also related to the number of vitrified oocytes that or the oocytes we injected, fresh or vitrified. And this is actually, also shown in this slide here. And when we increase the number of oocytes, either fresh or vitrified, then the rates also increases. And in this logistic regression analysis here, it shows how pregnancy rate is not related to the source of oocytes, fresh or vitrified, is independent on the source of oocyte, but is related to the number of oocytes injected. In other words, we can achieve similar outcomes with oocyte vitrification if we have a comparable number of oocytes. And this is to end in this talk. I would like to mention some technical issues that we cannot deny are related to vitrification as it is performed currently. There is a low reproducibility, as it has mentioned by different authors. And this could be due to there is a great variety of protocols and devices available. This is an entirely manual technology, so this is related to operator variability. We all know we embryologists love to make personal contributions to the technology. So at the end, this could be a totally different thing, the protocol we are doing. There are also, I would say, sensible steps, which are the exposure to the vitrification solution, and especially the incorrect elimination of the ES solution, which could make ice once in contact with liquid nitrogen. The volume in the loading, while loading the samples. Of course, inappropriate manipulation of the samples when placing these samples in the storage tank or when removing from these tanks. And I've seen really terrible things from bad practice, And in the warming procedure, which I think is a very, very critical and sensible step of the vitrification procedure, and the temperature of the thawing solution is really a critical step. We need to avoid any mechanical stress at this stage. And we don't know if the mixed protocols that we use for vitrification, and then we use different commercial supplies for warming, we really don't know if this is affecting or not. And I would also like to mention the issue of transportation, the conditions in which the samples are moved from one place to another. And thank you all for your attention.
Thank you so much for this really unbelievable and very comprehensive presentation, Anna. That was fantastic. If I may, I would like to ask just a few questions. You know, definitely you and your group were one of the pioneers to introduce vitrification. You know, started with oocyte vitrification because oocyte cryopreservation with slow freezing was not working very well. And then from egg vitrification, you know, we went to embryo vitrification also. So if you could tell me, what were the biggest challenges, you know, to introduce vitrification and to develop this technique to work as good as it is working in your hand? And how do you maintain consistency among different performers, among different persons who are doing vitrification? You know, because I think many of us have seen that there are, you know, variations from one person to the other, one group to the other. What do you think? What are the most important variables?
Yeah, I was going to say that the most challenging thing at the beginning was the learning curve for every person doing that. So we started doing this just one person, and this person teach the other, and the same person with the subsequent different people in the lab. We have a very strict protocol for the learning curve. We have a specified number of you know, the material that we get for practice. They have to get a specific survival rate with this. Of course, these are impaired oocytes. These are oocytes for trash that they are not useful, so we cannot expect high survival rates or high outcomes. But we have a standard, like a benchmark, even for these bad oocytes. So every person which starts needs to, you know, to overcome all these steps. And also we have a continuing protocol of checking ourselves, just to detect if everyone is doing different things. And very surprisingly, every time we do this, someone is doing a different thing. So this is why. So we need to keep on watching ourselves, just not to change this protocol. So that's why I do really hope that automotion of vitrification would be the next future step. But you know, my dream is that these machines doing vitrification would do the whole process, you know, vitrification and warming. And because somehow what we have today is kind of a mixed thing, and I think we will overcome the issue of the manual thing, the operator thing, if this is in the future. Is it really automotion with vitrification, automotive?
Okay, okay. And just to be a little bit more specific on one or 2 points, when somebody doesn't perform so well, what do you think? What are the biggest issues? It's the timing, it's the volume of the cryo solution around the egg embryo. Which part, you know, you see that is not handled well when the outcomes are not good?
Yes, I would say the timing when loading the samples. the volume loading the samples. And this is quite tricky when we are using biopsy blastocysts. And I mean, when we are using minimum volume system like the cryotop or similar, we had adjusted this volume, this loading volume for a biopsy blastocyst, because if we dry them excessively, they could get fixed to the surface of the device, and then the survival is not so good. And the other challenging point is the temperature at which the thawing solution is set when we are doing the first the step from liquid nitrogen to the solution. It needs to be warmed, 37 degrees Celsius. And I must say that in some of our settings, in some of our clinics, this was not we were not doing this so strictly. And it has really a great impact on the outcome, on survival rate.
Right. Very quickly, open versus closed. Do you see difference? Is it important for oocytes, less important for embryos? What do you think?
I mean, and this is really my personal opinion and my personal feeling, because we know that there are publications, clinical trials, randomized trials showing comparable results between open versus closed systems. But my personal feeling is that open systems still work better than closed ones. So if nobody obliges us to change, we are really not changing the open system.
Any risk using open systems? I know any risks using open systems. I know you have some publications to that possible contamination.
It's related to cross-contamination. We haven't detected, and you know this publication, even in high viral loads of hepatitis C virus, and there was no risk. And this is because someone said in the last in one of your webinars, in your past webinars, that dilution is the solution. I don't know if it was Lodo Parmigiani or someone who said, and I truly believe that when we work with this technology, you know, the successive washing steps, if there were any viral particle, it will be washed during these steps. So, so far we don't have this risk. No.
Excellent. Quick question. You had some slides saying that certain parameters predict or influence outcomes like age, endometriosis. Are there any other outcomes that you can relate to what will be the outcome of oocyte cryopreservation, vitrification? I'm sure that there are patients, fertility preservation patients especially, who will ask, okay, so what will be my chances if I freeze eggs? Is it enough? What can you answer?
This is a quite difficult answer. I really don't have the answer. What any other parameter, like for example, we are now focused on trying to detect in this healthy. Let's focus on the healthy donor population. They still, some of them have survival failure, which is really incredible in my opinion. So probably there are some markers, or there are some genetical markers, I mean, that could explain this lack of survival. So we are now focused on this way, trying to find some markers outside the oocyte in the specific person, and this would be very useful for fertility preservation, of course.
Yes. Excellent. Another question: fresh versus frozen transfers. You showed that in some patient population there is no really benefit to do a freeze-all. At the same time, some other studies, they very clearly demonstrate that nearly in all patient population there is some benefit. For instance, what happens if you have a patient that has slower developing embryos, and on day 5 maybe they have, you know, a morula or early blastocyst? Would you transfer that, wait for day 6 fresh transfer, or freeze and then transfer in a frozen embryo transfer cycle?
I mean, in these very particular cases, probably we will freeze all the embryos and let's see what happens with the cryo transfer. But the issue of freeze-all for all is what, at least in our hands, we were not able also to increase the outcome in the overall population. So probably in these cases, when you really don't know what else to do, why not? Why not? Because you are providing a more physiological environment for embryo transfer, and I think everything should add, right? But not really for all. Also because of the great impact in the logistics in your lab. So I mean, you need like thousands of tanks, and it has a really great impact in your
right. Do you freeze all embryos at the blastocyst stage, or do you freeze some patients' embryos at an earlier stage, 2pn cleavage, or it's all blastocyst?
Not anymore. We go for blastocyst and then freeze them.
Okay, last question. What do you think about the future? What will come in cryopreservation in the future? You mentioned about automation. Anything else beside automation?
I think automation, and I don't know, probably, and this would be also one of my dreams, specific protocols for specific samples. Because when we are vitrifying, we know that the behavior of not all the oocytes in the cohort and from patient to patient, not all of them behave in the same manner. The way that they dehydrate and then rehydrate is kind of different between samples. So if we could develop specific protocols according to the specific behavior in this real life moment, it would be amazing, I think.
Fantastic. Anna, thank you so much. That was absolutely incredible, this presentation, and I really enjoyed this conversation and question answers at the end. I really appreciate also in behalf of I3 and everyone who is attending this presentation. Thank you so much.
Thank you, Peter. The pleasure was really mine. Thank you so much.
And you know, I'm really indebted to Anna that she was willing to do that recording. Unfortunately, she was not able to be here today. She had an unexpected emergency family situation. She had to travel back to Colombia. And now it is absolute pleasure for me to introduce our next speaker, Anja Pinborg, who specialized in OBGYN in 2010, and she's an expert in clinical reproductive medicine and professor at the University of Copenhagen since 2013. Since 2018, she has been professor and medical and science director at the fertility clinic at Rikshospitalet. She has published 196 original papers and authored 7 book chapters. She was appointed editor-in-chief for the Danish Medical Journal in 2015, and she's former associated editor of Human Reproduction Update, RBM Online, and Acta Obstetric Gynecology Scandinavia. Her main scientific focus areas are reproductive epidemiology, including safety and quality aspects of art, with focus on child health, and clinical research on optimizing art and minimizing risk. And she's absolutely considered the best expert in the whole world about these topics. So it is really the greatest pleasure and honor to have you here. Thank you so much that you accepted this invitation. And please go ahead with the presentation that is about the health of offspring following frozen embryo transfer and frozen eggs. Thank you.
Thank you, Peter, for your very kind introduction, and good morning, good afternoon, and good evening to everybody listening here. And from here, it's evening in Copenhagen and turned dark now. I will try to share my presentation now. And thank you very much to the organizers also of I3 for inviting me to give this lecture. It's really a great pleasure being here. So the title of my talk is Health of Offspring Born Following Frozen Embryo Transfer, and what is best is that we have now heard two excellent speakers about the more lab techniques, and now I will guide you through the health of the offspring, which is also influenced by the things that happens in the lab. These slides here show the development in children born after ART in the Scandinavian or Nordic countries. This is figures from the Committee of Nordic Art and Safety, which is a collaboration of Nordic researchers that had collected data on children born from the beginning of the 80s to 2015 in the Nordic countries. And at the graph to the upper left, you see the development in the children born. So you can see the percentage of birth cohorts that are children, indicating that now 5% of the Danish birth cohort is comprised by children born after assisted reproductive technologies, and similar but a little lower numbers in the other countries. So a very high proportion. So it's certainly important for us also to follow the health of the offspring born after new techniques in assisted reproduction. We can also luckily to the in the upper graph to the right see that there has been a steady decrease in children born from multiple pregnancies, and now the numbers are less than 5% twin birth in ART in the Nordic countries, likewise in other European countries, in many European countries. Children born after ICSI had a steep increase in the around year 2000, but thereafter it lingers around 50% of the children born after ART. But let's have a look at the figure to the left. Down to the left, you see here that the number of children born after cryopreservation of embryos had steadily been increasing and are now accounting for about 40% of the children. So definitely, and I have to emphasize that far the majority of these children are born after slow freeze and not oocyte vitrification, which was introduced in the Nordic countries quite late. So the majority born after slow freeze. So we definitely have a need for research in the health of these offerings born after cryopreservation, which does not seem to decrease after we have just heard the very nice figures of the success rates after oocyte cryopreservation and embryo cryopreservation. Now let me emphasize on perinatal outcomes in children singletons born after cryopreservation or frozen embryo transfer. Here we see again a figure from the Konatas group published in Human Reproduction 2013, where we have looked at a huge number of children born after frozen embryo transfer, looked at preterm birth, low birth weight, small for gestational age, large for gestational age, high birth weight babies, and post-term birth. And if we look at the red columns, which represent the children born after frozen embryo transfer, we can see that there is a lower risk of preterm birth, low birth weight, and small for gestational age in these children, all significantly lower than after fresh embryo transfer. On the other hand, when we go to large for gestational age, high birth weight, and post-term birth, we can see a significant increased risk of these outcomes in the singletons born after frozen embryo transfers, indicating that there are some very important changes in the outcome of the children, and thereby also indicating that there are something with the cryo techniques or with the stimulation protocols that we use for the cryo techniques that actually ends up with high birth weight babies compared to the fresh embryo transfer, where we end up with low birth weight and preterm birth. And here's some studies by the Bartolucci group published by Maheshwari, the latest systematic review in children born after cryopreservation of embryos from 2018 in Human Reproduction Update. And here we see that the far majority of the studies, actually only one study, shows no difference between the risk of large for gestational age in frozen versus fresh embryo transfer. Clearly, in most studies, there is around a 50% increased risk of LGA children in singletons born after frozen embryo transfer. The same is seen for high birth weight above 4,000 gram, where we see an 85% increased relative risk of high birth weight in children born after frozen embryo transfer. And then to hypertensive disorders, including also preeclampsia. And this has also been shown in the Nordic cohorts that there is an increased risk for preeclampsia, shown here with 30% increased risk. Our recent unpublished data from the Conatus cohort have shown that this increase in preeclampsia and the increase in overgrowth in the children happens early in pregnancy. So something happens late in pregnancy, maybe influenced by epigenetic happenings in the early pregnancy. In this publication from 2011 in Fertile and Sterile, we have tried in the Danish group to look at the influence of parental factors versus the influence of the cryo techniques per se, including of course also the stimulation protocols for cryopreservation of embryos. And if we concentrate on the green lines and the blue lines, first we see with the blue line, this is a sibling study, so the same mother gave birth to both a child born after natural conception and then a second child born after natural conception. As expected, we saw that the second child always have a higher or have a mean higher birth weight of about 200 grams, which is shown in many studies that the second born child has a mean birth weight which is on average higher than the firstborn child. When we look at the mothers who gave first birth to a singleton born after fresh embryo transfer and then a singleton born after frozen embryo transfer, we could see a steeper increase in birth weight, that there was a mean birth weight difference of 300 grams between the child born after fresh and cryopreservation. And if we look at the mothers who gave first birth to a child born after frozen embryo transfer and then after fresh, we could see that there was no difference in birth weight. This indicates that when we keep the maternal factors steady and only look at the influence by the cryopreservation, we see that there is differences in birth weight indicating an overgrowth in children born after frozen embryo transfer. So the lab techniques or the stimulation protocols for cryopreservation do influence the birth weight of the outcome, of the offspring, sorry. Then let's have a look at school performance or long-term outcomes in children born after cryopreservation. We published in British Journal of Obstetrics and Gynecology in 2018 a national study in Denmark where we looked at school performance in children ending the 9th school grade after being around 15 to 16 years of age. And we saw in school performance overall school grades, Danish, in math, in English and science, we saw that children, singletons born after cryopreservation, had exactly the same school performance. And here I have to emphasize that 95% of the Danish children actually perform this exam and pass this exam. So very small proportion do not pass this exam, and that is mainly due to the fact that they are disabled or not attending public school due to maybe intelligence problems and so on. But in those 95% of the children who passed the exam, the school performance was exactly the same, which is very reassuring for the parents to children born after cryopreservation. Interesting studies have lately come up where the authors have compared programmed or substituted frozen cycles with natural frozen embryo transfer cycles. And with frozen embryo or programmed frozen embryo transfers, we mean cycles where the women have had estradiol and in the follicular phase and estradiol and progesterone in the luteal phase to mirror the natural cycle. But of course, in these programmed cycles, substituted cycles or artificial cycles, they have many names. There's no Corpus luteum. The outcomes of the offspring or the perinatal outcomes have been compared with those from natural frozen embryo transfer cycles with a corpus luteum performed either in a stimulated frozen cycle with low doses of gonadotrophins or in full natural cycles. And in these cycles where corpus luteum 0 pregnancy is compared to corpus luteum 1 pregnancy, we see that the risk of hypertensive disorders, postpartum hemorrhage, postterm birth, and the risk of a high birth weight child is significantly higher in program cycle. So maybe the difference in outcomes has nothing to do with the cryopreservation techniques, but rather with the protocols that we use. And this is from a National Swedish Register study. Another series of very recent and interesting studies have looked at the same, but looked into very specific hormone levels in pregnancies without a corpus luteum compared to pregnancies with a single corpus luteum. And of course, in a natural pregnancy, we have a single corpus luteum. In superovulation pregnancies with gonadotrophin stimulation, we have multiple corpus lutea, and in artificial or substituted frozen embryo transfer cycles, we have no corpus luteum. They have looked at relaxin, and relaxin is a very important hormone produced in the corpus luteum. Relaxin have very important influence on maternal, systemic, and renal vasodilation in pregnancy. So for the adaptation to pregnancy, the maternal vascular system is very dependent on relaxin. And relaxin also increases glomerular filtration, indicating another very important factor for adaptation in a woman to pregnancy. These series of studies was published by the Valerie Baker Group in Stanford and von Wersen-Hünk, which is a research group in Hanover. And they looked in the first paper on increased risk of preeclampsia and reduced aortic compliance in vitro fertilization cycles or frozen embryo transfer cycles without a corpus luteum or in the absence of a corpus luteum, so to say in substituted cycles. And they also looked at numbers at pregnancies with excessive corpus luteum and looked at the maternal vascular health in these pregnancies. And this was published in last year in Hypertension. Very interesting and preliminary findings. But here we see some of their findings, and we see the first column here with 0 corpus luteum versus 1 corpus luteum and versus multiple corpus luteus. And here we see that in pregnancies with no corpus luteum, relaxin, and again, I have to emphasize that this is a very important hormone for vascular adaptation to pregnancy in women. Relaxin was completely undetectable in women with no corpus luteum. We also found, or they also found, sorry, altered creatinine, sodium, and total carbon dioxide levels higher with no corpus luteum. So in these pregnancies with no corpus luteum, there were significant differences in these very important hormones for vascular adaptations in women pregnant, in pregnant women. So to say there is something happening in pregnancies where we have no corpus luteum, and I will come a little bit back to that, but just mention that maybe we should focus our research on optimizing and avoiding all these pregnancies with no corpus luteum and rather focus on optimizing natural cycle pregnancy, and maybe also the timing here can be flexible, so we don't need all these estradiol and progesterone to perform a frozen embryo transfer. Now let me turn to growth in pregnancy and childhood following frozen embryo transfer. Some recent interesting studies have shown that even though there is a higher birth weight and a higher tendency of being large for gestational age, it seems that this overgrowth in pregnancy levels out in childhood and adulthood. And this was published from Answorth in Fertility and Sterile in 2019 and for Besharati in very recent papers in JARC in 2020. And what these authors found was that fresh versus frozen embryo transfers has no influence on childhood weight, indicating that the overgrowth in pregnancy is leveling out or outbalanced in late childhood. The same was seen for the growth curves in children born after frozen embryo transfer, that they demonstrated no difference compared to other kind of offspring born to other kind of fertility treatment. And then a subgroup analysis of fresh embryo transfer versus fed groups for same outcomes also showed no difference in growth in the recent publication in JAG in 2020. So all reassuring data, and it may seem that this overgrowth in pregnancy is actually outbalanced in early childhood. Now back to the very interesting topic which Anja Cobo very excellently presented in the previous presentation. Also, child health after oocyte cryopreservation is very important, as oocyte cryopreservation is both after cancer or in relation to cancer treatment in young women, but also after oocyte donation is very important. And there have been some series of perinatal outcomes after oocyte cryopreservation, but this publication from Fertility Renewal by Anja Cobo in 2014 is actually one of the largest series, and they show in these pregnancies with 600 born after oocyte vitrification, 500 after donation, and 81 after own oocyte vitrification. They showed in these series of 804 pregnancies after oocyte cryopreservation only changes in first trimester invasive procedures, and in some changes in urinary tract infection, but this could be a random finding which was actually lower after oocyte vitrification. So overall, no differences in pregnancy outcomes after oocyte vitrification. They also looked at neonatal outcomes, and there was, of course, a small proportion of twins included, but they saw that there was no difference overall in neonatal outcomes after oocyte vitrification compared to fresh oocytes, except from a slightly higher proportion of female fetuses after oocyte cryopreservation. Also, Sethi and Noyes have published for the first publication on oocyte vitrification on a series of 900 singletons born after oocyte vitrification. So after all, reassuring on health outcomes. But of course, when this technique increases, we will also have more children born, and we will have to look also a bit more into malformations in these children. We have no long-term follow-up studies on oocyte vitrification. But back to the risk of cardiovascular impairment in children born after frozen embryo transfer. There are no literature on this at the moment, but what we know is from the background literature and the Barker hypothesis of development of health and disease in children, we know that LGA and small for gestational age can cause obesity and insulin insensitivity, and later onset metabolic disease, also cardiovascular disease, or type 2 diabetes. We don't know whether this is present in the children born after cryopreservation at the moment, because no such studies have been performed. But we know that frozen embryo transfer children are large for gestational age, and it might influence the later onset disease, cardiovascular disease. Therefore, what we know is that in IVF children from fresh embryo transfer, we know, and one of the largest series, although they are quite small, the group from Basel by Meister et al. Published in 2018, that children born after IVF fresh had a higher risk of higher systolic and diastolic blood pressure in the puberty. And this has also been shown in actually a systematic Chinese review, that there is a higher mean blood pressure in children born after fresh embryo transfer. This group from Switzerland also looked at parameters that are important for later onset cardiovascular disease. And that is, it's good to be able to have flow mediated dilation, to say that if the flow is increasing, it's good that the cardiovascular system is able to adapt and dilate the vessels, so to, you can say, adapt to the higher blood pressure. And this flow-mediated dilation was lower in ART children. They also found that pulse wave velocity was higher, indicating that a lower elasticity of the vessels in children born after IVF. And they also found a higher intermediate thickness in the aortic vessels in children born after ART. Very small numbers of children, but though it's a small case series, it indicates that there might be a high risk of cardiovascular disease in ART children, and we don't know whether this is also present in children born after cryopreservation. Therefore, we in Copenhagen have now set up a study which we are actually now performing, the HICARD study, Health in Children Born After ART, where we are including 600 children, singletons aged 6 to 9 years, and look at 200 born after fresh, 200 born after frozen, and 200 singletons born after natural conception. And we look into a lot of health indicators on later onset cardiovascular disease. That is a long row of blood sample on glucose, lipid, growth factors, angiogenes, cytokines, and also epigenetic markers for later onset disease. We also have a thorough clinical examination, and in particular blood pressure continuously measured to have a better score of blood pressure in the children. We also look at the body composition of the children in a DEXA scan, and 150 of the children had now gone through an MR cardiac scans. We have presented two of the abstracts, one oral and one as a poster presentation at ESRA this year. The preliminary results show that we have luckily no changes in the MR scans of the frozen and fresh embryo transfer children, although we overall in the cohort sees that there is a higher BMI in the children, indicating, and that's also shown in the naturally born children, indicating that children of nowadays are more inactive than they were previously. But we will have more, I hope to be able to present more results from this HICARD cohort in the nearest future. So the take-home messages is that short-term health in children born after frozen embryo transfer, we see that there is a higher risk of being large for gestational age when we compare to both fresh embryo transfer singletons and singletons born after natural conception. We also see a higher risk of high birth weight in these children and a higher risk of preeclampsia after frozen embryo transfer. And the risk is higher in the program substituted or artificial fed cycles, where we substitute with estradiol and progesterone in the luteal phase to build up an endometrium. But we know that this is an important issue, and I think coming research should really focusing on optimizing natural cycle fed instead of doing all these substituted with estradiol and progesterone. We now know that we might be able to perform a freezing cycle immediately after the fresh embryo transfer cycle without having any damage to the endometrium, which causes shorter waiting time. And we also know that maybe the timing of the XTG can also be flexible in these protocols without damaging the success rate. So we should focus on performing natural cycles fed instead of all these program cycles, even though I know that it's for logistic reason, but maybe we can also time and program the natural frozen cycles better. And then for the long-term health outcomes, there's very little evidence on anything on cardiovascular health in these children, and coming research will have to show. But we know that school performance after 9 years of school in 15 to 16 years of age children is similar after frozen and fresh and natural conception. And we also know from recent studies that childhood growth seems actually to outbalance the overgrowth in pregnancy in children born after frozen embryo transfer. So with these words, I will say thank you from Copenhagen and thanks to the organizers.
Dear Anja, thank you so much. That was an absolutely wonderful presentation with so many data, so many important information. So congratulations to you, to your team, to, collecting this data, analyzing, and, sharing, with all of us.
Thank you, Peter.
Just a quick question. You also told before starting the presentation that we have less data available on outcomes that is from vitrified embryos compared to slow frozen embryos. When we looked at our own data here at RBA, the babies born, the weight from singleton pregnancies, singleton deliveries, we saw that vitrified embryo transfers resulted in lower birth weight compared to slow frozen. Have you seen, similar data from others, and how would you interpret that?
Yeah, there are some smaller series now published also on slow freeze versus vitrified oocytes, but as far as I have looked, maybe there are some bigger studies now, but recently I looked it up, and I think it more or less looks that it's the same after vitrification and slow freeze, but I think we in the nearest future will have some large series where we look at oocyte vitrification. So to the point, we don't know actually now whether vitrification could be that it has a lower birth weight or better birth weight outcomes than after slow freeze.
Right. So we are getting to the end to our webinar in a few minutes. So I would maybe suggest one or two questions to Anja and Jeremy. Alison, what's your favorite question that you see?
Okay, I think I let Jeremy off too easy, so I'd like to go back to him. There were some more questions here that,
Right.
Jeremy, what is the optimal time after egg retrieval to freeze oocytes? I know we kind of go back and forth on this in our lab. Do you wait or freeze immediately after retrieval and stripping? What is your recommendation for that?
So here at RBA, we use the protocol. We did the retrieval 36 hours post trigger, and then we do the stripping about 38 hours post trigger, and we do the egg freeze 39 hours after trigger. That's our schedule. But I haven't done the study to compare different hours post trigger.
So that sounds similar to what you would do if it was a regular ICSI cycle, correct?
For the regular,
early?
It's a little early, yes. For the ICSI, we do the ICSI about 41 hours post trigger.
Okay.
Yes.
Okay.
And I think there is a question that I saw that relates to the same topic. After warming the eggs, what would be the optimal time to do the ICSI?
After warming the eggs, here, because we usually use 2 to 3 hours, because like the fresh ICSI time is 41 hours post ICSI. And then when we thaw the eggs, we usually wait 2 to 3 hours there to kind of like catch up the time frame for the ICSI.
Right. Maybe I have one last question to Anja regarding the recent publication in JAMA 2019 December, Hargrave and colleagues regarding that they saw correlation between the frozen embryo transfer that was associated with an elevated risk of childhood cancer, especially with leukemia, neuroblastoma, etc. So what's your interpretation on it? Because many criticize that study that for many different reasons.
Thank you very much for that relevant question. I maybe ought to have included the study in my presentation. I actually tried to send a comment to JAMA on this study because I know it very well, and we did a similar study a couple of years before, published in Human Reproduction, where we saw no difference overall in IVF children in cancers. So now they went into, and we decided in that study, which were actually bigger and included a larger cohort of Nordic children, we decided in that study not to perform any sub-analysis because we have too few children. In their study from Hargreve in Al, they actually had 14 cases of cancer in frozen embryo transfer children over 18 years. So it's based on, there's a huge number of comparisons in that study, so it could be a complete random finding. We are now trying with a larger cohort in all 4 Nordic countries to look into frozen embryo transfers, where we actually have numbers up to year 2015. And with all the 4 Nordic countries, the Hargreve study only includes Denmark. I think we now have a population that is big enough, but I think it should be really taken with caution before we see other studies, because it is based on 14 cancer cases in frozen embryo transfer children. And I was very sorry that they wouldn't actually publish a comment on that study, because it's highly cited, and I think it's a pity for the integrity in actually research that you are not allowed to post a comment on the study, because it has some limitations, definitely.
Right. Thank you very much. Alison, back to you. I don't know if you have more questions or if you want to close it down.
I think we have a lot more questions, but in the interest of time, it's probably best to round it up. I would just like to thank all of our speakers today for amazing, amazing presentations. I know we learned, or I learned a ton, and I'm sure everyone else did as well. And thank you to everyone else for taking the time to participate in this session. Again, thank you, Jeremy Chang, Anna Cobo, and Anja Pinborg. I also like to thank the organizing committee of this initiative, Peter Nagy, Thomas Elliott, Shaista Sadrudan, Jacques Cohen, and Marianne Saveztek. There is a tremendous amount of work that goes on behind the scenes to pull this off. And thank you all for the huge amount of time you spend on this endeavor. Also, one of the more complicated elements of these webinars is the stream of questions and the really well-organized way that it is triaged by the I3 team of Q&A panelists. Today's team was Liesl Nel-Tamat, Giles Palmer, Marianne Saveztek, and Shaista Sadrudan. So thank you to you as well. And with that, I'll hand it back over to Peter.
Thank you very much. And just as a reminder, we couldn't answer all the questions that you were asking, but we are going to ask the speakers, send them the questions, ask the speakers to answer those questions, and those questions will be posted also on the website. And with these thoughts, I also would like to encourage all of you who attended this meeting that if you have any suggestion, content, recommendation, please contact us and let us know. So far, there were 15 embryology and science organizations that pledged their support. And also remember, all of the sessions are recorded, so you can just go to our website, ivfmeeting.com, and you can look up any lectures. And I also wanted to thank Thomas Elliott, also my colleague, arranging all of this. Remember, next Tuesday, it's continuing. We are going to have a webinar on August 25 at the same time, same station, webinar number 30. It's about the secrets of implantation with excellent speakers like Joan Garcia Valesco, Yorgos Nikas, and Professor Nick Macklon. And before saying bye-bye, there is a very short video message that Jazz would like to play that is coming from one of our viewers. So if you want to share something similar, you can also send to us.
Hello, my name is Molly Payne. I am just coming to the end of my master's degree at UCL and will be starting a PhD at the University of St Andrews in September. I just wanted to mention our website and social media platforms. So if you've enjoyed today's sessions, please give us a like and follow on Twitter, Instagram, LinkedIn, and Facebook to keep up to date. They are regularly updated, so you'll never miss a beat. We'd also like to encourage everyone to get involved in future sessions, so please don't hesitate to use the Q&A button to ask any questions you may have. Any suggestions and feedback for future content is also welcome. Thank you for your time.
Thank you so much. And just to close it down, this webinar today was attended by over 650 attendees, which is, one of our records from several dozens of different countries. So thank you very much for all of you attending this, listening to us. Thank you for you speakers, and see you soon and be safe. Bye-bye.